Did you all get these links?
Yeah.
Wonderful. Okay, so I always have to I always have to check that those email lists are working because half the time they don't. Okay, great. So there's a bunch of salivary gland tumors on here. I've chosen sort of critical ones that I think you will encounter. And then, some differential diagnoses of those that are relevant. So because I liked doing this last time, I'm gonna force you guys to come up here and drive a slide yourself. So who's gonna volunteer? Come on down. If I use the Ward Reeves method, the first one is usually the easiest one.
Okay, yeah.
So you're in luck.
Salivary gland. Pixelated stroma. It has maybe fully encapsulated, can't tell for sure.
What gland are we in based on the normal?
So this is serous.
Mm-hmm.
Rotted.
Yep.
Okay. So zooming in, sides, all the mixed weight stroma, that's sort of paucicellular. We have well. Ductal.
Yes. Yep.
Sorry. Cells fall kind of not uniform. I want to say this is probably a PA. In that case, we want to make sure they got it all. Which,
Right. Right.
I don't really see a good cartilaginous component.
Right.
Although I don't need that.
No. Okay, great. Thank you. So, I mean, good. Yeah, just on low power, right? It's got these heterogeneously cellular areas with some more cells and some less cells. And you definitely do not need to see a chondroid or cartilaginous component. However, you do have a pretty good myxoid component, which is also still part of the, part of the PA spectrum. But yes, so you have a pleomorphic adenoma. A pretty conventional kind of diagnosis where, as pointed out, you do see bilayered ducts, right, with the myeloepithelial cell layer at the periphery and epithelial cell layer at the center. These are within the center of the tumor, right? So these are neoplastic ducts, not sort of entrapped at the periphery, so that's always helpful. And yes, myxoid, but not necessarily chondroid background. These individual cells are probably of myeloepithelial phenotype, and they're the ones that are secreting this connective tissue kind of mucin. So that's fine. No atypia, margins look kind of shelled out, but otherwise okay. Great, so pleomorphic adenoma. I'll just do this one, and then I'll have somebody do the third one. So, who looked at this one and can sort of give a differential for the second one while I drive it around?
PA, basal cell adenoma.
Mm-hmm.
I mean, it's well circumscribed, so
Yeah.
most likely to be benign. But
Yeah.
I thought the interesting thing was about this one. I felt like I was pretty comfortable with it being a basal cell adenoma because of this like basement membrane material everywhere. But what was puzzling to me was the lymphoid tissue that was around it. I was like, is it like a lymph node that's replaced? Or...
Yeah. Yes. Yeah. So remember that you can have two types of things, three types of things happening in salivary gland. You can have just tumor-associated lymphoid proliferation, which is not a lymph node, but just happens to be lymphoid stroma next to the tumor, just at random. And if you don't see a capsule, and if you don't see good capsular histiocytes, one could argue that this might not even be a lymph node, right? I don't see sinus histiocytes, I just see lymphocytes. So probably just tumor-associated lymphoid proliferation, may be related to the intrinsic nature of the tumor, may be related to biopsy. Secondly, you can have benign salivary tissue intermingling with lymph node tissue, and you can get tumors arising in that context, right? So you could have a tumor arising in or adjacent to a lymph node simply because of this intermingling of tissue, right? So that's 2. 3, it could be metastasis to an intraparotid lymph node. And generally that would not, unless you're dealing with like a primary tumor and then a metastasis in that same gland or in a separate gland. If there's no primary in the salivary gland, if it's only a metastatic site, then you're probably dealing with something cutaneous. So kind of the 3 things to think about with lymphoid tissue in the salivary glands. I completely agree that this is generally well circumscribed, albeit highly cellular, and you do see that just beautiful on H&E that this is biphasic, right? There's a nice myoepithelial cell layer and a nice epithelial cell layer. There is some eosinophilic stroma. There's also some eosinophilic secretions within the lumina, right? So let's kind of sort out the 2 types. I think this is intraluminal and this is probably stromal. So I think your differential diagnosis of a cellular pleomorphic adenoma versus a possible basal cell adenoma is a good one. And there are a few things that certainly if you had genetics that may help you sort things out, but you usually don't on salivary neoplasms unless you order it yourself. And it may not matter, because if you're going from one benign thing to another benign thing, I mean, it's a benign thing, right? So the bottom line is we agree that this is either benign or low grade. It's biphasic, and it has some stromal material. The other thing that we see here that is perhaps more suggestive of one over the other is this, which is what? Yeah, it's kind of a myxoid stroma. So do you expect more myxoid stroma in PA or more myxoid stroma in basal cell adenoma? PA, yeah. So more myxoid stroma in PA. Also these kind of nondescript, kind of almost spindly, plump myoepithelial cells might favor a pleomorphic adenoma. So why doesn't somebody, to sort out this, why doesn't somebody come up here and look at number 3? Andrew, because you already offered your diagnosis on number 2. Number 3 is gonna help us out.
Alright, so looks like, again, very well circumscribed. Actually, I take that back. I have this area over here, which kind of looks a little bit desmal, maybe a little bit of desmoplastia here, I'm not sure. And it's getting fairly close to the fats. And it looks like we're in a parotid gland here, so serous acini. But other than this area over here, it's pretty well circumscribed, very basaloid on low power. Looks like you have some secretions here. I don't see the myxoid area, at least that we saw on the other one. To tell for me if this is 1 cell layer or 2 cell layers. It's quite cellular. This certainly looks like 2 cell layers.
Yep.
Here.
Yep.
So again, I would give this kind of the same differential. Although maybe this one favored more of basal cell adenoma, just
Why?
because of the lack of myxoid areas.
Yeah, so the lack of myxoid areas and the presence of a couple of things which we'll talk about. And then just before we get to that, regarding that one area where you saw of that little trickling out into the desmoplasia, aside from invasion, what could that represent? With fibrosis around it and tugging,
Sialadenitis.
or
Stuff.
I mean, it seems like it's probably related to the tumor, so I would argue that it's probably not a metaplastic change, it's maybe a tumor related change. Biopsy site, right? So with kind of this desmoplastic fibrosis and tumor tugging into it in a solitary site, that could just be where they did the biopsy. Thank you. All right, so we agree that at least focally, we can appreciate the biphasic nature of this. But one might argue that the epithelial and the myoepithelial cells, in this area are almost more similar to each other, right? So it was harder to pick them out because they look more similar. They are also arranged not only in these tubular structures, but in these sort of larger sort of nests. And at the periphery of these nests, we see peripheral palisading, right? So that's thing one. Thing two, which we have to talk about and not forget, is this stuff, right? So these spindle cells between these large nests with peripheral palisading. And so what tumor did we talk about that has these very kind of cellular spindled stromal cells in between the epithelial nests? It was one of your two on the differential.
Basal cell.
Yeah, basal cell adenoma. So this picture here with these kind of shaggy, like, I don't know, it feels very like carpet-like, I don't know, you want to like pet or something, like these sort of streaming, like spindled cells, very discreetly in between these ductal areas. Sometimes the architecture of these areas is called tubulotrabecular, right, where you sort of have these tubules and trabeculae, and even these sort of intersecting jigsaw puzzle islands with this cellular spindled stroma. And so, yes, this is a basal cell adenoma. If you wanted to prove it, unlike pleomorphic adenoma, which is probably this one, what is the genetic profile of most basal cell adenomas? Mutations in
CTN.
beta-catenin, yeah, exactly. So you can throw a beta-catenin stain on here and see the nuclear expression. You could also throw your S100 on there and identify your spindled myoepithelial cell stroma. Otherwise, both PA, right, PA, probably cellular PA, and BCA are all biphasic, and so they will all have that P40C kit distribution of epithelial myoepithelial cells, with some differences in the morphology of those epithelial myoepithelial cell compartments and stroma. Okay? All right. Somebody next.
Just looking up here.
Yep.
What gland we're in.
Yep.
So it looks like we have mostly serous, so we're in parotid.
Yep.
And lesion over here. Well circumscribed, lobulated. definitely see that there are some very pink cells and also like a very deep background. The background looks very lymphoid, and then you have it's sort of lined by two layers of acidic. Standing out. So I would think that this would be important.
Yeah, perfect. So thank you. Not a super challenging one, but one that you will definitely see. Thank you. And is on the differential with some oncocytic lymphoid rich salivary tumors, which we'll see in a second. So Wharton tumor, you should expect this nice, this very, very even bilayered oncocytic epithelium. And you can see some epithelial proliferation, right? Like areas like this, maybe, for example, where you're more stromal poor, and you start to see kind of nesting of these little oncocytic islands. But in general, in the well-formed areas, you should have a nice oncocytic bilayer. And in fact, the parabasal layer is P40, P63 positive in Wharton tumors. So one could almost consider this to be biphasic also, but it's morphologically monophasic, right? Because it's all oncocytes, but immunophenotypically the basal oncocytes are P63, P40 expressing. So you could, if you are concerned, you could use that to sort of highlight that epithelial bilayer. Maybe, right? My theory is that is because if this isn't even a neoplasm, which we can't prove, we've never proven that this is neoplastic or clonal, maybe this is all just some kind of exuberant ductal proliferation, and maybe that's why you have this epithelial bilayer, because it's recapitulating the ducts. So I don't know, that's just my theory. But the same goes, I don't think I have an example here, I'm not sure. The same goes for oncocytomas, right? So oncocytomas that are oncocyte rich and stromal poor also have that same biphasic distribution of P63, P40 positive oncocytes at the parabasal, kind of at the stromal interface. Okay, so you can use that to your advantage if you have a differential diagnosis of another tumor. This maybe being an example of one of the things that could occur on your differential diagnosis. So I'll do this one. We also have lymphoid stroma. We also have kind of these very eosinophilic and cystic spaces, although the background stroma isn't quite as lymphoid rich, right? And so this is not necessarily one of the more challenging examples because we have an abundance of these cells, which are what? Mucocytes. And so when you see macrocystic, microcystic, and solid growth patterns with an abundance of mucocytes, what should you already have at the top of your differential? Mucoepidermoid carcinoma, right? And so there are variants of mucoepidermoid carcinoma that are rich in sort of more oncocytic types of cells, okay? So you can have a what they call this is not it, this is just a regular Wharton tumor, right? But you can have a Wharton-like mucoepidermoid carcinoma in which you have prominent lymphoid stroma, in which you have oncocytic epithelium, but also, right, probably the presence of mucocytes. And the other difference between mucoep and Wharton or oncocytic lesions is that aside from the mucin-rich cells, essentially all of the cells of the mucoepidermoid carcinoma, the intermediate cells, the squamoid cells, all express, what's the marker we just talked about? Yeah, P63, P40, right? So So if you have diffuse, more than just peripheral expression of P63, P40, you could help support a mucoepidermoid carcinoma, because the predominance of cells are positive, for that. What is the fusion of mucoep? Mammal, right? So MAML, mammal 2, is either fused with CRTC1 or CRTC3. Okay, so we often use fish in those circumstances. If we have a high index of suspicion for mucoep, we can use fish to prove it for mammal 2. Okay. This is probably, just given the location of this here, are we in a minor or major salivary gland? We're probably in a minor gland, right? Because we have squamous mucosa and we have some more mucin as opposed to serous-rich salivary. So this could be palate, this could be buccal space, right? So mucoepidermoid carcinoma is one of those that can occur in any salivary gland site, minor and major glands. So have a high index of suspicion for it. Unlike something like Warthin, which generally we only see in the parotid. Basal cell adenoma, similarly, mostly parotid. PA, honestly, it can be anywhere, right? So you can have pleomorphic adenomas in the minor and major glands. You can even have them in the soft tissue or skin. So in the deep soft tissue and or the skin, they have somewhat of a different name, but they are essentially morphologically and immunophenotypically and even genetically the same with PLAG gene rearrangements. What are the names for those in those different anatomic sites? So in the deep soft tissue, they're often called benign mixed tumors. And in the skin, you know, I'm forgetting. Help me out here. Oh my God. Syringoma. No, not syringoma. Oh my God, my mind is blanking. All right, somebody Google it. Oh my God, I'm totally blanking. So basically, you can have a biphasic, PLAG rearranged, chondroid or myxoid rich tumor in any of these anatomic sites in which the name essentially varies. Chondroid syringoma. Thank you. So chondroid syringoma in skin, benign mixed tumor of soft tissue, pleomorphic adenoma of salivary. Same thing. All right, BCA, Warthin, mucoep. Okay. Next.
Like when circumscribed, like so as a capsule around, but I also see like the tumor outside of the capsule. So I guess it has a specific pattern. So that maybe favor malignant setting.
Okay.
This just a low power.
Yeah.
And also it looks low power. So so at higher power. These cells like remind me of the cells that are like in the acinine, but in a more disorganized fashion. So if I go to higher power, they have like granular cytoplasm and run so it looks like the cells that are normally like serous acinine. So about cell carcinoma. Yeah, that was my only research.
Yeah, I mean, that is an answer, exactly. So at a cynic cell, exactly, right, normal. So a cynic cell basically only occurs in the parotid after, showing acinar cell differentiation. You can prove that those are, thank you. You can prove that those are serous by either looking at H&E and seeing the zymogen granules, which we can very well see in this case. Or you can do your PAS diastase, if you wanted to, because the zymogen granules will not be digested out. So yeah, those little guys. The other stain that we talk about with the cynic cell is dog1, having apical or kind of luminal expression. I don't have a scan slide of that, I'm sorry, but we don't use it very often because usually the morphology is obvious. What was I gonna say? Oh, the thing with the cynic cell is that it can be very circumscribed, but we still regard it as a malignancy. In this case, there's perhaps some infiltrative looking growth, as pointed out, beyond the capsule and perhaps into or adjacent to the normal gland. Although this all still looks like tumor, so I don't know. Who knows? This maybe just be a tangential section, whatever. So in the pancreas, right, something with similar morphology would be called acinar cell, right? In the salivary glands, it's a cynic cell. We don't normally use the like the tryptase, the chymotrypsin, whatever those enzymatic immunohistochemical stains are, like they do in the pancreas. We do not use them here because they don't express that. So it's basically just PAS diastase, dog, and we talked about the recently discovered gene in these, which is NR4A3 fusions. There is an immunostain, not really commercially available. I mean, not really readily available, but for research purposes, some people have shown that the NR4A3 stain works and to show that it's acidic. But okay, cool. All right. I'll do the next one since you guys just maybe had something similar to this recently. All right, what tissue are we looking at here? Thyroid. What tissue are we looking at here? Yeah, it looks like cartilage with respiratory glands and respiratory mucosa adjacent to thyroid. Yeah, so we're probably dealing with something, right? Some larynx or tracheal cartilages. Fine, that have become focally ossified. So then in the neighborhood, there's this infiltrative neoplasm with, give me one word for this morphology. Cribiform, exactly. So when you see cribiform morphology and highly infiltrative, your diagnosis is essentially what? Adenoid cystic, exactly. I think I gave you one of these on the search path exam, so you just saw it. But you know, remember this can occur in major salivary glands, minor salivary glands, ear canal, trachea, bronchus, larynx, all places of minor salivary gland, breast. You know, we already GYN tract. So have, you know, with cribiform morphology and biphenotypic or biphasic, think adenoid cystic. We already talked about how even though these cells look kind of similar, these are of epithelial and myoepithelial cell differentiation. So your P40 and your c-KIT will highlight those. We've already seen that in the presentation, so I'm not going to belabor this. Okay. All right, adenoid cystic of the trachea with invasion into thyroid cartilage. Genetics. MIB NFIB, yep, or MIB L1 NFIB. There is a MIB immunostain, we don't have it. We usually just end up doing the RNA fusion panel because I think sometimes these immunostains can be a little bit not specific. Okay. Who's next? Emily, do you want to come? Thank you. And this is a tough one, so a description with a differential is going to be good.
the cells look.
Yep.
I'm wondering about Salivary carcinoma or hydrating or clear cell carcinoma.
Awesome, awesome. Thank you. Yeah, so thank you, Emily. The key point that she brought up, right, is that this is high grade, right? So you've got your most important clinical indicator, right, is that this is a high grade carcinoma. It's very solid. There's arguably, even though the border is kind of lobulated, it seems that there's kind of this stromal kind of desmoplastic infiltration. There's that central necrosis that we saw. There's kind of a lot of apoptotic and mitotic debris, prominent nucleoli. So you're dealing with a high-grade carcinoma. And for treatment purposes, that's the most important thing that you need to get across, because they're going to treat this much more aggressively than they would a low-grade carcinoma. Yeah, right here, these large nests with central necrosis. And so the large nests with central necrosis certainly architecturally brings up the differential diagnosis of salivary duct carcinoma. Arguably, if you look at the cells that are lining these spaces with central necrosis, what would you expect to be the morphology in a salivary duct? This looks very blue and basaloid with not a lot of cytoplasm. Is this compatible with what you normally expect in a salivary duct? Not really. Salivary duct is much more almost apocrine, right, with lots of voluminous eosinophilic cytoplasm. And you can also say, well, Nicole, there are like these cribiform spaces or these kind of Roman bridging spaces that you talked about in salivary duct. Oh, here, right? Like, so that's present. True. But again, the cytomorphology doesn't really fit. And the fact that you have these kind of almost cribiforming or you know what they might call in salivary duct Roman bridging, also, right, morphologically raises the differential of what thing that we just saw. I'm not trying to trick you, which would be adenoid cystic, right? So you also can have that on your differential because you have a suggestion, right? A suggestion in some areas of a background kind of cribiform morphology in the absence of apocrine cells, but the presence of very, very blue, very basaloid, right? So when we think of very blue, very basaloid, certainly adenoid cystic is one of the things we want to keep on the differential, but the biphasic nature of this is not as apparent because you've got replacement of most of the lesion by these large high-grade cells with prominent nucleoli, mitoses, etc. Right? So if you were to do your P40C kit, you might be able to prove biphasicity in some of these more cribiform areas. But in the solid areas, these are generally monophasic. They can be monophasic epithelial, C-kit, or they can be monophasic myoepithelial, P40. But in general, because the morphology of the epithelial and myoepithelial cells in adenoid cystic is quite similar, you may not be able to make that distinction on H&E alone. But your trigger, right, is this is a high-grade salivary type carcinoma, in which if you needed to, you could prove adenoid cystic by genetics if you needed to, but you've given the clinical team their treatment protocol, which is this is high grade. Look, okay, so this is a high grade adenoid cystic. But I thought it was a nice example of what happens when salivary carcinomas turn high grade. They often lose a lot of their underlying kind of hints as to what they are. So you have to look carefully and or use genetics.
Is the treatment for adenoid cystic versus high grade adenoids different?
Yes. So the treatment for high grade any salivary is different than low grade any salivary. Caveat being, with most adenoid cystics, even if they don't have overt high-grade transformation, they generally upfront treat them a little bit aggressively with wider local excision, maybe also with neck dissection, just because even the non-high-grade transformed adenoid cystics behave worse. But once they have high-grade transformation, then they're gonna pull the trigger more on like systemic chemotherapy, and more radiation. Whereas non-high-grade transformation, if it's clean and if it's clear, they may stop at local resection, maybe radiation. So yeah, there's a little bit of extra aggressivity that they'll do for high-grade transformation in terms of systemic therapy. Okay, so 8:40, that's fine, you've all taken your turn, I can go, all right. Also parotid. All right, malignant or benign? Malignant, excellent, right? Salivary carcinoma with infiltrative lobulated growth, malignant, right? So circumscription doesn't always mean benign, but because circumscribed can be malignant, as we saw in the acinic cell, but infiltrative is always malignant. Quite monomorphic looking, maybe with some suggestion of ducts. Let's see. Not overtly high grade yet, right? Pretty bland, pretty monotonous, not a lot of mitosis or necrosis. Be careful of entrapped ducts, right? Not to overinterpret these as tumor, right? So you have a nice kind of ciliated thing with inflammatory debris. So probably an entrapped duct, just like maybe some entrapped over here. All right, but the tumor is sort of laying down this pink stroma. And if we look carefully, do we think that this is monophasic or biphasic? This one's a little hard to tell. But in areas, we almost get the impression that there may be a cell type that's forming an epithelium of a duct with some secretory material in it. But a lot of these cells in the background are these kind of monotonous cells with what's prominent about these cells? Clear cytoplasm, right? So we have an infiltrative neoplasm that's kind of monotonous, that we're trying to debate whether there's one or two cell types. What about here? Yeah, looks like two, right? Looks like there's this sort of double lumen, probably bilayered duct, epithelial, and myoepithelial cells. And many of the neoplastic cells in the background have this clear cytoplasm. So we have probably biphasic, probably infiltrative, occasional areas of clear cytoplasm. Here are some nice areas too, where probably that's duct and duct. Okay, so now what's your differential? So biphasic, at least based on H&E, which we can, well, is true if you do the immunostains. Infiltrative, differential. What are our infiltrative biphasic tumors? We already saw one of them, adenoid cystic. Does this look like adenoid cystic overtly? No. All right, what else?
Epithelial, myoepithelial carcinoma.
Pardon?
Epithelial, myoepithelial.
Epithelial, myoepithelial carcinoma. Wonderful. What else?
Basal cell adenocarcinoma.
Basal cell adenocarcinoma. Wonderful. Do you have a favorite based on those?
Second one.
The second one, which is
Basal cell carcinoma.
basal cell. Okay, you're favoring basal cell adenocarcinoma. There are a few things that I'm going to argue against for that. So we can, I think, all agree that this doesn't have the morphology of adenoid cystic that we have seen in the earlier couple of slides. Maybe you're favoring basal cell because of the stroma.
Yeah,
What else?
but if reminded me to the basal cell adenoma that we saw earlier.
Uh-huh.
But invasive, like.
Okay.
so-
Okay, sort of an invasive variant of basal cell adenoma. Yeah, so the things that might favor a basal cell adenocarcinoma might be this hyalinized basement membrane material. But remember that if you have a tumor that has myoepithelial cells in it, you can have basement membrane material being secreted even if it's not a basal cell adenocarcinoma. What's a little bit maybe missing from the morphology of a basal cell adenocarcinoma is those jigsaw puzzle architectures, right? That those really intersecting, really basaloid blue on low power. We don't really, maybe there's a very hint of peripheral cells, but we don't have that nice tall peripheral palisading. We don't have that extremely blue or basaloid architecture, but we do have this very monotonous, very bland kind of clear cell cytomorphology. And so that's almost a good trigger for you to think more strongly about the other one on your differential, which is epithelial myoepithelial carcinoma. So epithelial myoepithelial tends to not have those jigsaw puzzle arrangements with peripheral palisading, but it does tend to have these biphasic things with very clear myoepithelial cells in the background. And so even in these bi-layered ducts, you can see that there's good cytoplasmic clearing, and we certainly saw that in an area somewhere, right, somewhere over here. So in cytoplasmic clearing, think about something that is either a pure myoepithelial cell carcinoma, an epithelial myoepithelial carcinoma, or for that matter, one of the hyalinizing clear cell carcinomas. You can knock out hyalinizing clear cell carcinoma because of the ducts, and you can knock out myoepithelial carcinoma because of the ducts, right? So you're kind of mostly left with this one based on morphology. What's the molecular profile of epimyoep? HRAS. So just like thyroid follicular neoplasms, it also has RAS. So keep epimyoep on your differential of biphasics with clear cytomorphology. Okay, cool. Questions? All right. Next. Product. Kind of a little bit of a blurry border, right? A little bit of a blurry border. Diagnosis. Secretory carcinoma, right? There's so when you get a good example, you can make the diagnosis on H&E. So per our question of do you need molecular or whatever to prove it, not always. So this is a classic example of secretory carcinoma that is pretty well circumscribed because it's low grade, although it does have a blurry border with infiltration into adjacent, so you can tell that it's malignant, right? And it has these, one could argue, almost cribiform appearing spaces, right? We have these back to back glands, but the cytomorphology is very, very, very monotonous, and it has this intraluminal, very watery, milky, right, kind of secretory material. So if you were to want to prove this, and you did your, so if you did your 3 stains, right, which we normally do for salivary, right, our 3 stains are P40, C-KIT, and S100, what pattern would you expect in this? P40 negative or positive? Negative. So P40 negative, because this does not have a biphasic phenotype and it's not of myoepithelial cell phenotype, so P40 negative. C-KIT, maybe positive, but kind of in a random distribution. So you wouldn't see nice, like, perfect ducts in it. It probably is just going to be kind of patchy random. S100. Positive, diffusely strongly positive. Probably because this is again of that intercalated duct phenotype, right? So diffusely strongly positive for S100. And what other stain is this positive for? Secretory carcinoma came from the world of breast, so it's positive for mammoglobin. Gene fusion. TV6 NTRK3. So this is one of the many NTRK tumors in the body. You might ask about, since I mentioned breast, I'm thinking about it myself. You might ask about GATA3. So most salivary tumors are GATA3 positive with rare exception, and I have a chart somewhere I can send it to you. But GATA3 to me does not help because a lot of them are positive because salivary and breast tissues express similar immunophenotypic markers. Mammoglobin is the one that is unique, right? So mammoglobin is only positive in a very small subset of salivary tumors, unlike GATA3, which can be positive in men. Okay, so this is secretory. I know it's a little bit blurry on the scan, but maybe we can make out that, you know, the nuclei are relatively small and round and monotonous. Maybe there are small nucleoli. You don't see a lot of mitosis necrosis, but you do see, right, all of these diffuse kind of secretions. So secretory, secretory, secretory carcinoma, however you want to call it, that's this. Okay, good job. All right, now we are in an anatomic site that looks like, I don't know if that was cauterized epithelium or what, but we have a significant amount of mucinous glands and ducts, and I'm gonna imagine that this was probably a surface squamous epithelium that got sloughed off. So if we are in a squamous epithelial line site with a predominance of mucinous glands, where are a few locations that we could be at? Could be submandibular, although submandibular tends to have did you say submandibular or sublingual? Submandibular. Submandibular is not really connected to mucosa. So submandibular is more adjacent to skin, and submandibular is going to have mixed serous and mucinous. Sublingual is more close to mucosa, right? Because you kind of get mucosa, sublingual, submandibular, skin, right? So could be sublingual, although sublingual arguably also has a small proportion of serous cells. Where else in the oral cavity has squamous mucosa and a predominance of mucinous? Palate, right? So think about the opposite side of the mouth, palate. So very, 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 very common to palate is this picture of really, really mucinous rich glands with an overlying squamous epithelium. All right, so we are probably in the palate. Okay, again, just based on low power, benign or malignant. Malignant, we have infiltration into the adjacent mucinous glands, excellent. Oh gosh, whoa. Perineural invasion already, so that's a malignant sign, okay. And nerve entrapment here again, so lots of malignant signs. We have this sort of focal myxoid stroma with almost this like kind of tornado or like this whirling kind of pattern. And we have these monotonous cells. And again, like we normally do, we're gonna look to see if we think this is monophasic or biphasic. And so we're gonna look in these ducts or these duct-like structures. We're gonna ask ourselves, do we definitively see an epithelial myoepithelial bilayer? You're kind of going, man, exactly. If you can't really see it, it may or may not be there. You can always stain for it, but if you don't see it on H&E, chances are you're probably not going to see it on IHC. So you have these nested, tubular, even cribiform, right? So cribiform isn't pathognomonic of adenoid cystic, but cribiform is a morphology that you can see in many tumors like we've seen. You kind of have to have the conglomerate of circumstances, right, to call something adenoid cystic. In this case, how are the nuclei different from what we saw in adenoid cystic, for example? That's often on the differential. More open, right? Very open chromatin, kind of grooves and wrinkles. Oh, look, there's my mitotic figure. Some people have likened these nuclei, for better or for worse, to papillary thyroid carcinoma, where they're kind of elongated, grooved, wrinkled, open chromatin. Okay? So what is your differential diagnosis here?
Polymorphous versus adequate cystic.
Polymorphous adenocarcinoma versus adenoid cystic carcinoma. You certainly wouldn't be, in this case, would not be considering it a benign thing, right, like a polymorphic adenoma. So throw your three things on there: P40, c-KIT, S100. P40 negative or positive? Negative, so polymorphous is monophasic, so 40 negative. c-KIT, same problem, probably patchy, right? Patchy could be positive. S100, usually strongly positive. Mammoglobin, negative, exactly, right? So that could be a good help if you're trying to think about a monophasic thing, secretory versus polymorphous. Mammoglobin will be differentiating here. Also, genetics. What are genetics of polymorphous? Also starts with a P, PRKD1. PRKD1 mutations or fusions in the cribiform variant. So polymorphous is one of those that I think we are now becoming much more familiar with what it looks like. These have been misdiagnosed as, if they're more circumscribed, they've been misdiagnosed as polymorphic adenomas because they've mistaken those ducts for having bilayers. They're misdiagnosed for adenoid cystic because they have infiltration and have PNI on the palate. So just be very, very cautious. But we have good morphology, and we have good immunomarkers that can help us differentiate. Okay, so this in fact is a really, really good example of polymorphous adenocarcinoma with PNI, with that characteristic like whirling or targetoid stuff, with these very sort of, I don't know, like fluffy. I don't know what the word for it is, but on low power, it's kind of like, it's very cloud-like. It's very, very pale, kind of pale purplish to pale pinkish, rather than that really dark, right, basaloid look of adenoid cystic. So I kind of like to use the high and the low power all together. Okay. Oh, even a better example of palate, right? So now we have squamous mucosa with a nice layer of mucinous salivary below it. We have your palatal musculature here, right? So great, this is good normal palate. All right, now what do we have?
Clear cells.
Extraordinarily clear, right? Extraordinarily clear cells with pretty small, round, wrinkled nuclei. Infiltrative or not infiltrative? Highly infiltrative, right? This thing is percolating out into the adjacent mucinous salivary tissue. It's dripping down into the fibrous stroma. All right, so malignant. Look, there's even a nest out here. All right, so we talked about what your differential could or should be if you have abundant clear cells. Along with one of the characteristic features of this tumor, hyalinized stromal cords. So this is hyalinizing clear cell carcinoma, right? So your differential diagnosis might be a clear cell myoepithelial carcinoma. What we already saw epimyoep, but for all intents and purposes, there's no epi here. We talked about the genetics of these, which are one of our favorite fusion partners, EWSR. EWSR with ATF1. And we talked about the immunophenotype, right? These stain-like squamous, hymolecular weight keratin P40, P63, but none of the other myoepithelial specific markers. No contractile markers, no S100 SOX10s, right? Okay, so hyalinizing clear cell carcinoma, generally, even though it's infiltrative, generally of low morphologic grade. And, ooh, perfect. Last one. I think this is all one that you can all shout out because you all know what it is. Central necrosis, large ducts, cells that are very plump cytoplasm with large nuclei and prominent nucleoli. There's your quote unquote Roman arch or Roman bridge, right? But otherwise kind of cribiforming in these nests, right? We talked about this on the differential of that other one. We talked about this on the differential of the solid adenoid cystic. But this is much more eosinophilic with prominent nucleoli. So it's salivary duct, right? So unlike that solid adenoid cystic that had a similar central necrotic morphology with peripheral cells, you can appreciate how much more apocrine-like, right, these cells are. I'm gonna go back to that one in a second, but giant nucleoli, much more abundant eosinophilic cytoplasm. And even sometimes you can see this fuzzy luminal border with a little bit of maybe like apocrine, almost like snouting, right? So that's more common in salivary duct. Where was the, right here, right? So here is your super blue, right? Super basaloid, solid, high-grade adenoid cystic. Not so much cytoplasm, no apocrine snouting here. Yes, you can have nucleoli because that's what you have in high-grade salivary carcinomas, but you are lacking that abundant eosinophilic apocrine cytoplasm. You're lacking the apocrine snouting, and you're lacking this kind of Roman bridging or Roman arching. So what would you expect this to be positive for that might have clinical treatment implications? Androgen receptor and HER2, yeah. So notice the more abundance of cytoplasm here. So this is salivary duct. So P40 negative, S100 negative, androgen receptor HER2 positive. Remember that some of these large ductal spaces can actually, most of these are infiltrative. If you were to throw a P40, this would just be dead negative. However, in some examples of salivary duct, you can have P40 lining the periphery of these large nests with other areas that are infiltrated, implying that there's some kind of intraductal spread, almost like DCIS, right? So it can travel up the ducts. So if you see a P40 layer, that's okay, that can happen in these cases, but you should expect the majority of this to be P40 negative, because it's all infiltrated, okay? So salivary duct. I don't see a background pleomorphic adenoma here, although we know that this is one of the ones that commonly transforms. Okay, questions? Can I confuse you more?
Have you ever seen, so hyalonizing clear cell carcinoma, have you ever seen metastatic RCC or something else metastasize to a salivary gland like that?
Yes,
So rule that out.
yes. So clear cell RCC can metastasize to thyroid, we know is common, to jaw, to salivary gland, to oral mucosal, yes. So that would be easy to do with like a Pax8, CA9, all those renal things. Presumably, metastatic RCC would also be negative for like your high molecular keratins, your P40s, P63s. But yeah, absolutely. Yep. There's not to toot my own horn, but if you're interested in clear cell things, we wrote a review article in Head and Neck Pathology on the top 10 clear cell rich lesions in head and neck. And so HCCC, metastatic RCC, all those things are on there. And it gives you a nice kind of differential diagnostic table of what your immunostains are, et cetera. So yeah, so check that one out. In fact, there was a whole series of articles, if you're interested, on top 10 whatever, top 10 neuroendocrine tumors of head and neck, top 10 clear cell things of head and neck, top 10 whatever. So that's a really nice article collection to kind of help through some of these differentials. Okay. Thank you all. It's been a lovely head and neck and bone and soft tissue whatever. Here, block, that's the word I'm looking for, block. Okay.